Everybody can hear me well. Thank you very much, Stephanie, for the nice introduction. I'm very proud to being able to talk to you today about the vet welding technology, and I'm going to do a quick introduction, and then I'm going to introduce to you the Weldix resorbable bone anchor, show you some applications and techniques where we have used it, show you some cases, and then some future ideas that we had where we could use this technology. But we're going to go back to the 90s first, and we're going to start with woodwelding, so furniture building, because that's where the base of all the vet welding is located. And they discovered that they could use an ultrasonic energy to form a bond in porous materials. In this case, wood. As you can see, these are two different types of wood that are connected with each other. And they discovered that it's a very quick and easy to use technique. It showed a superior fixation compared to adhesives and traditional solutions that we also use in our daily repairs at home, like screws and nails. And something that's a bit of a hot topic lately, sustainable technology. So back in the 90s, this was a faraway story, but now this is something that's very hot topic. So just to show you how this technology works, so we're going to start off at the left side with a piece of wood. The blue part above it is a thermoplastic element that we fixate on a sonotrode. This is the gray part on top of it. And we're gonna put some ultrasonic energy through this thermoplastic energy, and the shearing forces at the polymer surface cause this element to liquefy and to penetrate into the surrounding cavities, which shows a stable bond after only a few seconds. And one of the main advantages that we will see also in our veterinary patients is that it cools very, very quickly. So quickly over the advantages: strong attachment, fast to use anywhere you want, clean and efficient. Of course, this sounds like music to our ears and also to the ears of the human orthopedic surgeons. So they invented bone welding, which is used a lot in maxillofacial trauma repair. And on the right picture, you can see a resorbable screw, which is liquefied and fixated into the bone. Up there, we see a plate that's being used. And this is an example where they try to reconstruct a mandibular defect, where they use a titanium plate to keep the mandibula in place. And they use a type of mesh where they put in an allograft or an osteograft to get new bone to be formed. So this technique is also available in veterinary medicine. So vet welding also has a lot of plates, as you can see here on the right, some meshes, some foils with pre-drilled holes, but you can also drill your own holes. And the benefit is of this mesh and of these plates with a hot water bed, you can fold them and contour them to the surface where you want to fixate it. And then of course they have some types of pins like the sonic pin or the bone anchor to use them. And we're going to talk about the bone anchor a little bit later. Then there came spine welding, where it's used in spinal trauma, spinal correction, where they developed a type of pedicle screw that can be fixated together with the polymer into the bone. And they did a lot of experiments on sheep, so studies osteosynthesis of fractures of the mandibular condylar base, or the use of bone welding technology in spinal surgery has been examined. But one particular study in 2009, the ultrasound-assisted anchoring technique for fixation of implants to bone, a histological study, was very interesting because they noted that new bone was formed at the implant without evidence of inflammatory reaction, and the amount of adjacent bone was increased compared to normal cancellous bone. And definitely very interesting was that there was a mild and short temperature increase during insertion. So then what's interesting for us about the topic today is sport welding. So using this technique into tendon and ligament trauma repair. And as we all know, in also veterinary surgery, suture anchors are prepared methods for securing ligaments or tendons to bone. And again, there are two interesting studies. One where they're going to compare a non-absorbable versus an absorbable suture anchor for an open blanket repair, which is a repair of shoulder instability in human medicine, which showed very good results for the non-absorbable suture. But the second one, the 2020 paper, which where Dr. Burnham presented his initial experience with the bioresorbable polymer anchor, is something that's really interesting for us as well. So he tested this on ankle surgery, and as you can see on the top left picture on the right, the gray part, this is our sonotrope, the little blue part on top, this is our polymer, and then we have a suture on it. So he drills a small hole, puts in the suture, and then he's gonna pull it. So he's gonna lift the leg on the anchor, showing that it has an immediate strength inside of the bone. So he noted that it was a safe procedure, it showed clinical effectiveness, and there was a low incidence of adverse events, mechanical failures, and infection. And of course, this for us is very interesting, and that's why Vetwelding introduced this into veterinary medicine. And I'm gonna introduce to you the main character of our little story today. That's the Weldix 2.3 millimeter anchor, which is a polylactate anchor. It's biocompatible, fully bioresorbable through hydrolysis, which means in the end we only have H2O and CO2 left. So its dimensions are very small. So it has a 2.3 millimeter diameter, 7.2 millimeter in length, and we need a 1.8 millimeter drill hole of 7.6 millimeter in depth to insert it. So it's based on the same bushing technology that Woodwelding is based on. So it uses ultrasonic energy. As you can see on the left schematic here, we have the gray part, which is our sonotrope. We have our Weldix anchor or our implant that we are going to use. And with pressure and with ultrasonic energy, the implant liquefies. It flows into the cancellous bone and it solidifies, immediately binding to the cancellous bone. So for us, I think it's very interesting that it has minimal thermal impact and there is no impaired bone healing or osseointegration. Having a closer look at the implant itself, so right on the tip we have two grooves. This is here on the left side. The distal groove is used for the bigger sutures, the 2/2 to 2. And then the smaller groove, more proximately, is used for the 4/3 sutures. And currently there are 3 types of sutures available for this implant: a polyglycanate monofilament, non-resorbable polypropylate, for instance, monofilament, or the multifilament, the polyester, the ones that we use most commonly, for instance, in cruciate ligament, cranial cruciate ligament repair. This is a short video. I hope the video is playing well, but I think so, to show you how the anchor is being implanted. So this is the Weldix absorbable anchor. We're first gonna drill a small hole of 7.8 millimeter. This is a special drill provided by Vetwelding. I'm gonna show this later. Then we're gonna put our suture on the distal tip of our implant, and then a combination of ultrasonic energy and a constant pressure of 10 Newton. We'll put the anchor in place, it liquefies, it immediately solidifies, and it forms a strong bond, and you can pull at it immediately. So then they did a comparison between the Weldix anchor, an all suture anchor, and a mechanical suture anchor, and the Weldix anchor pull-out strength was superior to that. So that's also something that I find really interesting in this technology. This is an in vivo image on what it looks like. I'm going to repeat it a couple of times. So they tested the pull-out strength in human medicine, and there was no alteration for 12 months in the pull-out strength. Now, animals we know have a little bit of a higher temperature, so the estimate is that it will last for at least 6 months, which is exactly the time that we need for periarticular fibrosis to be developed after ligament trauma or joint instability. So when Steph and I, Manuela and I were thinking about doing this webinar, we were like brainstorming, what is it like, or what do I think about it? And if we look at all these advantages and the easy way to use it, for us and for me also, it's a perfect match, the Weldix anchor combined with ligament repair, because quality of fixation is crucial, and we can immediately test this during our surgery. So for the moment, the Weldix anchor can be used in smaller animals like cats or dogs less than 10 kilograms, or in small dogs, or in dogs with smaller joints, like toe joints, for instance, in larger dogs. That's also a possibility. So about ligament injury, and this is probably the most common type of injury that we see in our patients. And it can go from a minor sprain or a strain from a tendon, which is a grade 1, up to a grade 2, where there's a little bit of joint instability involved, up to a grade 3, like in the cat on the right side, which has a complete disruption of his tarsal joint, where the joint and the ligaments are obviously damaged. And grade 1 problems cause a bit of a challenge in the diagnosis, and grade 2 and grade 3 make it a little bit more difficult in the treatment. Of course, the most common rupture that we see in our patients is the cranial cruciate ligament rupture. And I'm not gonna talk about into detail about anatomy, because I think that is very well known. What I find very interesting from the cranial cruciate ligament is that although it's located intra-articular, there is a little synovial sheath around it that makes it extra synovial. So as soon as the cruciate ligament rupture, it becomes intra-articular, so it causes some kind of foreign object reaction, which creates an inflammation inside of the joint. And I'm going to get back to that later in our treatment. So the cause: acute trauma, sporting dogs, degenerative problems, older dogs, and some predisposing factors like obesity, dogs with Patella Luxation, contralateral rupture. There's always been a discussion, or for instance, dogs with Cushing's disease are predisposed for cranial cruciate ligament rupture. The force mechanism is most commonly an internal rotation and a shearing force with a partial flexion of the knee on the cranial cruciate ligament. And then depending on how strong this force is, we have a complete or a partial rupture. So the symptoms goes from a minor lameness, grade 2 out of 5, up to really a non-weight bearing gait or dogs tiptoeing. And as we all know, a positive cranial draw sign is pathognomonic for a cranial cruciate ligament rupture. In case of uncertainties, we can add an MRI or radiographs to our diagnostic protocol, or of course visualize the cruciate ligament like with arthroscopy on the left image, where there's a complete rupture of the cranial cruciate ligament, or in the right picture where there is a partial rupture of the cranial cruciate ligament. We're not going to talk too much about all the different types of treatments that you can have, because otherwise it would take us, I think, weeks, and we still wouldn't know which type of treatment would be the best. I still find it funny in that case that when I talk to referral vets, for instance, that for dogs, it's known a cruciate ligament rupture, we have to do surgery. In cats, very often there's still a discussion about should we do it, shouldn't we do it. So important factors to consider are: is there a meniscal damage? Is there a tendinopathy of the long digit extensor? Or is there a Patellar Luxation, which is causing the problem, or which is secondary to the ligament rupture? Animals in pain, we need to help them, of course, as quickly as possible. And the tibial translation, which is definitely a problem in cats. And I think you also see a lot of cats in your practice that come in with a cruciate ligament rupture, a positive drawer sign, and then you take an X-ray and you see that there's some kind of osteoarthritis located in the joint. And then we know that these cats have had problems for a longer period of time. So this is a small list of all the possibilities, or some of the possibilities that we have. We're mainly going to focus today on extracapsular stabilization, because this relies on periarticular fibrosis to be formed to stabilize the joint. Of course, osteotomies, I mean, I do TPLO and TTA as well. They alter the joint mechanism in a way that the cruciate ligament becomes obsolete. And then, of course, there are the intracapsular stabilization techniques, which are also a possibility. Now, all of these guys will probably tell you their way is the way to heal or to treat cruciate ligament rupture. I'm not gonna say this, I'm gonna stick to extracapsular stabilization and gonna show you where the Weldix anchor can be of a benefit into the treatment. So this is the technique I like to use the most, and I'm gonna compare this with another, a tunneling technique. So on the left side, we're gonna use 2 Weldix anchors to create a completely extracapsular stabilization. On the right side, we're going to use a tunnel in the proximal tibia and a Weldix anchor in the distal femur, and one part of the suture will run through the joint, which of course can cause irritation of the joint as well. And I like to make the knee joint as clean as possible, remove all particles or as much particles as possible of the cruciate ligament, that I know that we have a clean joint that can heal very well after surgery. So we're going to focus on the left technique. And this is what we need. We need non-resorbable multifilament. On the left side, the middle drill bit is the one I like to use the most. So Vetwelding provides you with 2 types of drill bits, says 7.8 millimeters of length. And this one has like a conical shape on top, which will create a little stop as soon as you hit the cortical bone, that you cannot drill the hole too deeply. On the right side, you can see our bone welder, or the bone welder with the handpiece, sonotrode, and then we need a 1.8 millimeter drill bit. And this is a cadaver that I used to show you how we're going to do a cranial cruciate ligament rupture repair with this technique. So I like to use the F2 and the T3 points. Those have been described by Don Hultz as near isometric points to repair cranial cruciate ligament rupture. And we're first going to drill the hole at the T2, at the F2 point. And I just saw that my blue point on the left picture is a little bit too cranial. So just look at the point of the needle. This is the distal point of the lateral fabella, cranial to the margin of the articular cartilage. So this is the point where you want to insert your first Weldix anchor. So we're going to drill a hole in this region, and I'm going to show you what it looks like afterwards. Then we have a small hole. Very important is that you make sure that the hole is clean, so that there are no remnants of bone tissue or soft tissue around it that could impair the implantation of the Weldix anchor. And remember the direction in which you drilled the hole. So this is a small step schematic showing you how to drill the hole, and this is actually real time. So this is the time that it needs to drill this hole, and as you can see, it goes very quickly. We put some pressure on it, 10 Newton, which is actually a lot of pressure. We tested this before. Polymer liquefies, and you can immediately test the pull-out strength. So this is what the finished product looks like. And I like to test it as well. So I'm just going to pull on the suture and try to pull it out. And I have to admit, the first 2 cases that we did, I'm always a bit curious when I try to test out a new technique. I had my assistant hold the femur very hard, and I really tried to pull this implant out, and I didn't succeed. So that was a good testing. Then we're going to drill a hole at the T3 point in the proximal tibia, which is located at the bony prominence caudal to the long digital extensor groove. And we're going to drill this hole completely to the medial side. So this is our point, the blue point, as you can see. And you can slant the drill hole a little bit distally as well. That's not a problem. So this is a view from the front. As you can see, the patellar tendon in the middle. The patella is located on top, and the drill bit is going completely through. And then I like to use a wire passer to pass the suture through the hole. This is a point where I sometimes like to check if the cranial drawer sign is already gone. So almost always this works out very well, that I know that my points are selected correctly. And then we should switch to the medial part. This is where I always have an assistant who pulls really hard. So I always tell her to pull hard on sutures, one suture proximately and one suture distally. And putting a little bit of extra rotation on the tibial tuberosity, and we are going to insert another Weldix anchor right over here, fixating our suture into the proximal tibia. I like to put 3 knots on there just to make sure that everything stays in place. And at first I thought these knots were going to cause a problem because we're on the medial side of the proximal tibia. There's very little soft tissue coverage. I informed the owners that maybe we have to remove this knot under minor sedation and some small analgesia after a couple of weeks, but this does not seem to be any problem. So I keep on doing this knotting technique. And then, of course, what we all do after a cruciate ligament rupture repair, we test for a positive drawer sign. And this is not me shaking or anything. So this surgery, left side is proximal, right side is proximal, left side is distal. I'm really trying to put out this line. So we did about 5 cats and 3 dogs up to now, and what I find very interesting was that I always do my surgeries alone. I learned this from the beginning as a resident. Unfortunately, we did not have many assistants in Belgium, so I do all my surgeries alone. But of course, when I have to tie the knot or have to pull the suture, then I ask my anesthesiologist to scrub in very quickly. And in all the cases, they always say the same thing, now already. So for me, that shows that surgery time is shorter, but of course, this is not evidence-based, this is my own experience. And when I compare the results of these cases with the other cases that I do, and also the feedback that I get from the physiotherapists, we have comparable results. So, but like I said, this is my experience, this is something that we have to look into evidence-based in the future. Of course, what we all want to know when we learn about a new technique is complications. And we want to learn from them, but we never want to have them ourselves. So I had one suture breakage. The suture broke 2 centimeters away from the anchor. So I think this was just bad luck. Sometimes the suture breaks. Yeah. And then we had a problem with backflow in 3 implants that we implanted, 2 in the same cat. One backflow means that the liquefaction of the Weldix anchor is not working. So it liquefies not into the cancellous bone, but it comes out again. And then, of course, if you pull the suture, you pull it out immediately. So one of the reasons that I found in one cat is that we put the F2 point in the femur, we put it too far caudally. We had too little cancellous bone to work with. And that was, I tried it 2 times, it didn't work. We put a hole, drilled a hole 2 millimeters more cranially, and it worked perfectly. And then we had one backflow issue where I had the direction of implantation wrong. So this was a surgical error. The benefit of the technique is you can recover very quickly. So if you have an implant in place and you're not certain if it holds up or not, you can drill it out again and put in a new implant without any problem. So that's what we did with the second case. Patella Luxation, I find these very frustrating to treat. Always a big discussion, so should we do surgery immediately or not? I don't want to create a discussion on this one. The most difficult species are cats for me. So in dogs, we have a lot of surgical treatment possibilities, like the sulcoplasty, tibial tuberosity transposition, the lateral suture, the medial desmotomy, the lateral fascia overlap, or even reducing patellar size, which is something I don't like to do, but in some cases it's necessary. In cats, the problem is that it's very often young animals where growth plates are still in place, most commonly to the medial side, often a bilateral problem. Cats anatomically have a larger patella, which very often results in cutting away part of the patella. Like I said, I don't like to do this. They have higher physiological laxity, so a lot of cats have like a floating patella, which is perfectly normal. So first we have to make sure that no other problems are there, like hip dysplasia, for instance, or back problems that cause this. So cats might cause a surgical challenge. And definitely also a post-op treatment challenge. Not only the cats themselves, they're not so happy to work with, and then of course the owners who do not want to keep the cat in a room for a longer period of time. So just like in plastic surgery, something that we should think about is maybe just tighten the strings in those young animals. So this is the same cat. This is a right knee, where a cadaver, where the upper blue point is the upper point of the patella, and the lower blue point is the lower point of the patella. This is the patellar tendon. And this is the point where we want to fixate our Weldix anchor, and we want to pull the patella a little bit more laterally and a little bit deeper into the patellar groove. So this is a known technique where we're going to put a suture around the patella right below or into the patellar tendon. Going to implant our Weldix anchor the way we did it in a cruciate ligament rupture. And as you can see, I left one part a little bit longer, and I'm going to show you why, because this is an interesting technique. If we pull on one part of the suture, we can really pull it through the Weldix anchor. It stays in place, and we can tighten the upper part of our suture. So I'm going to repeat this image again, just that you can have a look again. So we're going to pull it and tighten up the patella. So normally in a living animal, we put some blood or some saline on the implant, and it goes a lot smoother than in this case. But very interestingly, the suture stays in place very nicely. And then you can just tighten up the lower part, putting a finger on the patella, keeping the patella nicely in place. And you don't have to worry about damaging growth plates, especially in the proximal tibial tuberosity. This is a case that we had. This is actually the first case I used the Vetwelding, the bone anchor system on. This was a 7-year European short-hair cat, 4 kilograms. It was hit by a car, and as you can see, it has a massive trauma to the tarsus, a tibio-tarsal luxation. You can also see that there is a small fracture of the distal styloid of the fibula, and there's a little bit of cartilage damage inside the bone as well. So I discussed the owner all possibilities. I told them probably this will end up into an arthrodesis. We can do an amputation, or we can discuss euthanasia, or we can try to repair these ligaments. But because of this cartilage damage, prognosis is very questionable. The owner did not want arthrodesis because it was too expensive. And of course, amputation and euthanasia were out of the question. So we decided to use the Weldix anchor to repair these ligaments. These can be also very challenging because, as you know, there are a lot of little bones in there. There are a lot of little ligaments in there, joint capsules in there. And if there's a massive trauma like this, everything breaks. So all the stabilizers are gone. So there are a lot of techniques described where you can replace the ligaments with sutures if the insertion parts are still there, or you need screws or washers or anchors to insert them to do a prosthetic repair of the ligaments, both medial and lateral. So we decided to go for an open reduction. I did a lateral reconstruction with the K-wire, immediately stabilizing the joint laterally. And I have to admit, I got a little bit cocky there, and I did not do a tension band system because I thought we're going to keep this cat nice and long in a bandage for everything to heal. And then we did a medial reconstruction using a Weldix anchor, and I'm going to show you the picture straight away. So here on the left side, this is the left malleolus of the distal tibia, and you can see the cartilage damage there. So I called the owner again during surgery, let them know there is still a risk that we will have to do an arthrodesis later in life, but let's go for it, let's try this. And it worked out really well. So we got this joint stable in like 5 minutes with the anchor system. As you can see over here, we put in an anchor right in the middle. I used a little tunnel there to stabilize the joint, and afterwards we tried to reconstruct the joint capsule. So my initial plan was to do a cast for at least 6 weeks, maybe even 8 weeks, do a 10-day interval change, and do a radiograph after 6 weeks. Now, after 10 days, the cat went to the referral vet. She checked everything. The joint was nice and stable. It had a nice normal range of motion. And the lady, an 80-year-old lady, thought after 14 days the cat could run free. She removed the bandage. The cat went outside. And 4 days later, the cat came back in, limping because, of course, my tension band system failed. And the referral vet told me that the medial part was nice and stable, but the lateral part was not stabilized anymore. The owner did not decide to proceed with further treatment, and the cat is actually doing quite well. She sent me a video, but it's not good quality because she has an older cell phone. But you can see that the cat is using all 4 legs, and the referral vet told me as well that the medial side is nice and stable, but she has a small lateral luxation when she walks. So I also did some cadaver pictures for you to have a better idea on what it looks like. So on the left side, you can see the medial tarsal ligament, which is cut through, and the blue points are the points on the right side that we're going to use for our fixation technique. So on the left side, you can see all the Weldix anchors being put in place, and then we're going to just put the sutures together, tighten the strings again, making this joint stable. Other indications or other ideas that we had where we could use the technique, I haven't used it yet, but it looks really promising, and techniques with other suture anchors have been described, is like medial shoulder instability or shoulder luxation. As you can see in this poodle on the left side, he has almost a 90-degree shoulder abduction test. So this would be very interesting to test this on smaller dogs and cats as well. Another indication could be elbow luxation, as you can see here. On the right side, there is a lateral reconstruction, and on the left side, there is a medial reconstruction, which is always a little bit more challenging. So I'm going to show you what we did here. So in the medial part of the radius, and the lateral part of the radius, we're going to insert 2 sutures, which is possible with the Weldix anchor. In the ulna, we used 1 suture and 1 Weldix anchor, and in the radius over here, we are using 1 suture and 1 Weldix anchor, which gives you the possibility of doing a figure of 8 stabilization. So all surgeon preference, what you like to do, but you can do multiple sutures into 1 Weldix anchor, also 2 sutures in 1 Weldix anchor without a problem. Then some other cases that some other colleagues of mine did was recently we heard about the Achilles tendon repair in the cat, which looks schematically a little bit like this. And these can also be very challenging if we, because there's very little soft tissue located over here. And caudal cruciate ligament rupture has always also been described. You can see these cases on the Woodwelding website, and biceps stenodesis has also been described in a single case as well. Contra-indications is also always something that I want to know where we can use it and where not. So quantitatively or qualitatively inadequate bone tissue, that is something where we don't want to use it. Minimal or no cancellous bone structure, and that's where the caudal part of the lateral femur in a cat in cruciate ligament rupture repair is a bit tricky, because if you go too caudal, there's very little cancellous bone available there. So that's the reason why I like to test the draw sign during surgery to make sure that we have a nice and stable repair. Like in any orthopedic surgery, soft tissue or skin infections or massive local inflammation, adequate circulation, those are all contraindication. A bad general state of health. We did 1 dog with Cushing's disease with the Weldix anchor. He recovered really well. Or if there are any known allergies or reactions to synthetic materials. This is more in human medicine a case, and this is something that we very often do not know in our patients. Incorrect implantation technique. Really remember what direction you drilled the hole in. Unsuitable suture material, only use the sutures that have been tested, where we are certain. And then remember our cat with the tarsal luxation, where the owner decided to let it run free a little bit too quickly. As you can notice, I'm still frustrated about this case. So inadequate post-operative load reduction and immobilization. So this is the introduction or the information that I wanted to share with you. I want to thank you for your attention, and I hope that I tickled your interest a little bit in using this technology in your patients. So I'm going to hand over the word to Steph now, and if you have any questions, please do not hesitate to ask them. Thank you very much.
Hi, everyone. I'd like to thank you again for joining us this evening. So as Yuri said, I do hope that this has tickled your interest a little bit more in using resorbable suture anchors in your practice. So, you know, what I like to say, you know, kind of as the sales guru here at Welding is, you know, we aren't reinventing the wheel, especially when it comes to cranial cruciate ligament repair. We know you guys love TPLOs, and for good reason. What we offer basically is the possibility, the absolute possibility to use bone welding to integrate it into your veterinary practice. So, you know, we saw that we can do CCLs with the extracapsular fixations with the suture anchors, but the patella luxation, the tibial luxations, shoulders, elbows, tendinosis, these are all reasons, you know, that we could use bone welding in your practice, that you can integrate it in. And as you heard from Yuri, it's very easy, it's very quick, it's gonna cut down on your surgical time, it's gonna cut down on your anesthetic time, which is gonna lower your anesthetic risk for your patients. And, you know, the number one reason we are literally all in this is for patient care, and doing the best for them that is absolutely possible. So, at this time, we'll turn over some questions. If you guys want to turn on your cameras, if you'd like to just pop in and say hello and see all your beautiful faces. And if you've got any questions that you'd like to ask in real time, you can just hit the hand raise button on the smiley icon on your toolbar, and we'll be happy to talk to you. I know some of you guys have got some questions. Is there anything else that you would like to add, Yuri?
No, I think one of the questions that hopefully some of you guys have is, where can I get it? So go to Stephanie. She's sitting right beside me. So we're Corona-proof, 1.5 meter. Yeah. So no, ask them for a demo. Ask them to stop by, because that's how they convinced me when they first came here. I mean, we talked I think 2 years ago about the technology, like a first brainstorming session, and then it was quiet, and then suddenly they popped up last year to me, and they said, hey, we have this thing that looks promising. Do you want to try it? And like I said, test it yourself. I mean, the first thing that we did was I took a cadaver, I put in an implant, and 3 people pulled it. Three people tried to pull it out, and it's like some of you guys really also do hip replacements. So if you do a total hip replacement and you want to test it out afterwards, you don't want to go easy on the implants. You want to know if it can withstand all the forces that the animal is going to put in it. And that is exactly what you can do with this implant. You can immediately pull it, and if you pull it out, then put in a new one without any problem. Yeah, it's going to be not so easy to pull it out. So I'm looking forward to some videos out there of people pulling it out. Yeah, I should have not made a video of me and my assistants trying to pull it out. That would be nice. Yeah.
We can if you don't like how your anchor was placed, you can pull it out and you can re-drill.
Yeah, exactly. So that's the reason why I like to test the stuff out, and that's what I like about this technique. You put in the anchor, you can immediately see an effect. If you have backflow, for instance, if you see that the anchor is not fully in place, you can either pull it out if it's possible, or if you're not happy, just drill a new hole right where the anchor was. So you can put in a new anchor without a problem. So that's what we did in the one cat where we had the issue with the backflow, and again it worked out very well, and we even created some backflow in some of the cadavers that we did as soon as we knew about this problem, and this works really well. So I was not allowed to say dummy proof, but I'm gonna say it anyway. So no, but I mean it's like that. Yeah, you can really correct any failures that you have, and yeah. So, but like I said, I mean, for me, I'm using it next to my TTAs, my TPLOs. But in smaller dogs, in cats, I like to do the extracapsular technique because it's works very well. It's still one of the better techniques out there, and of course, money-wise for the owner, that's always a very big issue. Also in Switzerland, so it's the same here as anywhere in the world. Yeah.
So yeah, like Yuri said again, if you want to meet up, I mean, I've gotten on planes with a week's notice. You know, if you've got a surgery that you want to try the machine out on, I can drive. I will take a train. I will go anywhere that I need to get you guys, you know, to get your hands on this technology, because that's the most important thing, right? You can watch 100 webinars on the same thing and it sounds so cool and it's, you know, so new and, you know, and so awesome sounding, but it's not going to really make any sense to you unless you've actually, you know, you're holding it in your hand and you're pushing that first suture anchor in, and your mind is being blown by how fast and easy everything is, you know. And then another reason I really love talking, you know, to you surgeons is, you know, I mean, I was speaking with one today here in Switzerland, and, you know, he'd never seen, I mean, he'd seen, you know, everything online, but he'd never actually handled it. And, you know, he was just, I mean, it was, you know, 25 minutes of him being like, I could use it like this, I can use it like this, and pulling up pictures that he had saved from surgeries that he'd done, and saying, I could have used it in this surgery, and oh my gosh, well, what about this indication? This sounds really great. So, you know, it's a lot of fun for me, especially being a former nurse, not only to talk to you guys, but to also see your excitement when I bring this machine to you and you get to try it out, and, you know, you see just how awesome it really is to use. So any in-person questions? We've had some chat questions so far. Manuela, is there anything that you would like to add tonight?
No, I think I just want to thank Yuri for the great presentation, and yeah, if there are any questions from the audience, or also if you think about some questions that maybe come into your mind now in the evening or tomorrow, then yeah, email us or get in touch with us. We're happy to answer them, and we're also happy to do a demo for you at your practice.
So I posted my email address in the chat. If you guys need it, just copy it down, stephanie.waite@vetwelding.com, and email me directly. Or if you forget that, we've also got the info account, info@vetwelding.com. We'll get back to you with everything. So Conrad's got a question, so I'm going to go ahead and unmute him. Hold on, Conrad, hold on. Wait. Now you're muted. You need to unmute yourself.
Okay, good evening. So first of all, Dr. Béosier, thank you very much for this very interesting talk. It was really a pleasure and I learned a lot. And then, you know, maybe one thing which maybe was not so much emphasized, but you know, the bone welding machine, right, Steph? You can use it actually not only for the anchors, but it's the same machine for the plates and pins.
Correct. We also have a plate and pin system that is also polymer based. It's a little bit of a different polymer. So functional time with the suture anchor is 6 months, which is fantastic. Functional time with the polymer that we use for the plates and pins is 8 weeks. So We typically use the plates and pins for non-load bearing indications in craniomaxillofacial disease processes.
Okay. Do you plan a similar webinar also for plates and pins?
We do, yes. Hopefully, our plan is that we'll do a webinar every quarter. So my plan, fingers crossed, hopefully, I can get to the US and speak with one of our dental surgeons over there who will be happy to do the plate and pin webinar. So look forward to April, May for that, hopefully.
Great. And Manuela, one question to you. So we saw that there is a limitation of 10 kilos. Maybe could you explain why this is the 10 kilos and what you actually have? Do you have something in mind to overcome that limitation?
Yeah, so at the moment, as you saw, the Weldix or the 2.3 millimeter anchor is for sutures up to 2, so USP size 2. And it's more or less the suture is the limitation at the moment. So we cannot get larger sutures into the anchor. That's why we need a larger anchor to have the indication for the larger dogs as well.
So I guess, can you then use the same machine and the same sonotrode to push in a larger anchor?
Yes.
Okay, so it's basically open system. Cool, thank you. Again, thank you, Yuri, for this great talk.
Thank you. Yeah.
Thank you, Steph, for organizing it. It was great.
Thank you very much for giving me this opportunity. It's very exciting and very excited to meet you as well, because we have never seen each other or spoken. So no, thank you very well. And I'm looking forward to a couple of more cases left in the upcoming weeks. So I'm looking forward to using it. Yeah. If I may. Yeah, I'll let you talk. I just want to make one small comment, because Manuela, about the bigger anchors, so I wasn't sure if I could mention that, so that's the reason why I didn't do that. So I will leave it to you. But now that it's out in the open, so there are even some techniques with like TPLO that have been described where they will add a lateral suture to prevent internal tibial rotation. So that would be very interesting for all you guys out there doing TPLO, to add this technique to your TPLO surgery, because it will not take up that long of your surgery time to use it. Yeah, so and I like the machine. It's like really small. You can put it everywhere you want to. So yeah, so all the feedback from my assistants who have to clean it and everything, I don't hear anything negative about this. Yeah, and then I let Steph tease you guys a little bit more about something else.
So I'm not really sure how many of you will be attending SBOT this year, but we have decided that we will be doing one of the pre-labs. So Yuri and I will be putting on a half-day dry lab with both the Weldix suture anchor and the pin and plate system, the Resorb pin and plate system. So if you're there, hopefully stop by. I've got all your email addresses already. So I will email you all of the information about the dry lab that we're putting on. And like I said in the beginning, we'll send you the recording of the meeting as well. So you'll get some questions in there. And yeah, email me if you've got any questions or you want me to come to you. I'm more than happy. So anything else? Well, I think if that's the case, then we can probably log off, and don't forget to check your email and spam folders in the future. And hopefully we'll see some of you or all of you soon. So thank you. Have a great weekend, and yeah, enjoy your night.
Thank you. Bye-bye.
Bye-bye. Setting meeting.